Thanks. Good afternoon, everyone. Welcome to the Department of Medicine Grand Rounds. Before we start, I wanted to acknowledge the recent passing of Dr. Tom Martin, who is a professor emeritus in our department. Tom was a member of our department and our division for over 30 years. He was the vice chair of the Department of Medicine and head of medicine at the VA. And he was an absolute titan in our field. He had 30 years of continuous research funding from the NIH and the VA, and had published over 200 papers that were tremendously high and highly impactful. Uh, Tom was the president of ATS in 2003, where he was instrumental in initiating the ATS Foundation Research Scholarship. And perhaps the thing he was most proud of was that he was the scientific director of the Parker B. Francis Fellowship Program from 2008 to 2018. This is a picture of Tom here on the left at ATS, absolutely in his element, giving the most constructive and sort of encouraging feedback to a trainee. As many of us know, he was a mentor to dozens of trainees throughout the nation and the world, quite frankly, who have gone on to be leaders in their fields of study. And he was absolutely beloved by his family, friends, and our UW community. This photo down here was a wedding in Montana in June, where he's surrounded by, you can see here, about a half dozen of our trainees and junior faculty. And so nothing could be more Tom. Our division is planning a memorial, and we'll give details out to the department later. With that, I'll hand it over to Hannah.
Yeah, thank you so much, Dr. Morrell, for taking the time to honor Dr. Martin. And thank you all for coming today for Grand Rounds. My name is Hannah Weaver. If I have not met you yet, I'm one of the inpatient chiefs at Montlake. We will be asking questions at the end, so I encourage you to drop your questions or comments in the chat, and we will review them during the Q&A session towards the end. Right now, I'm going to introduce Dr. Rena Mira. She is going to introduce our speaker for the day. She is the head of the Division of Pulmonary Critical Care and Sleep Medicine. Please give her a warm welcome, and thank you all again for coming.
Thank you so much, Dr. Weaver. It's a pleasure to be here, and thank you to Dr. Morrell for that poignant overview of Dr. Martin. His loss has really been very devastating and heartbreaking for our division community. So along those lines, I'll introduce another leader of our department, Dr. Butler, for whom this lectureship is named. It was said that his zest for life equaled his dedication to science. He was division head from 1965 to 1985, and he grew the division from 1 to 28 faculty. He was born in Grantham, England, and he received his medical doctorate from the University of Birmingham. He had an extraordinarily deep passion for science, and that really has served as the nexus and bedrock of scientific excellence that has remained and continues in the division. His investigation focused on the bronchial and pulmonary circulation, and he directed SCORE and program project grants, and he was a member of ATS and the American Heart Association. On a personal level, John was an English gentleman, had youthful energy, a verve for life, found on weekends to be hiking and surfing, and he developed a real passion for gliding when he served in Germany. He was stationed there and developed a passion during World War II. So the Butler Lectureship is based upon his unfortunate and tragic death in 1992 in a glider accident. And for the Butler Lectureship, what we do is we invite a leader in our field, a leading scientist to Seattle to interact with our trainees and our faculty, our learners, to honor his love for teaching and research. And so we're very happy that Dr. Doug White has accepted our invitation. And I would also like to point out that the structure for this has changed this year, and that we have an actual scholarship day that is now surrounding this Butler Lectureship as well. Then we're grateful for Dr. Morrell for organizing that. So given that Dr. White's visit here has such special meaning, given the ties to our Dr. Randy Curtis. I've asked Dr. Aaron Cross, who's the director of the Cambia Palliative Center of Excellence, to provide the introduction. So thank you, Aaron.
Good afternoon, everyone. It's my pleasure to welcome Dr. Doug White. Dr. White is a professor of critical care medicine and holds the UPMC Endowed Chair for Ethics of Critical Care Medicine. He also directs the program on ethics and decision-making in critical illness, where his research spans both empirical and normative ethical analyses, particularly focused on surrogate decision-making for patients with life-threatening illness. Dr. White received his medical degree from UCSF, where he also completed his residency in internal medicine, his fellowship in pulmonary and critical care, a master's degree in epidemiology and biostatistics, and a fellowship in bioethics. He eventually did leave UCSF and joined the faculty at the University of Pittsburgh in 2009. Over the course of his career, Dr. White has received extensive federal and non-federal grant funding and has authored more than 200 peer-reviewed publications. He's an elected member of both the American Society for Clinical Investigation and the Association of American Physicians. You see around me. Early in his career at UCSF, Dr. White sought additional mentorship from our own beloved former colleague, Dr. Randy Curtis. Many of his early publications were co-authored with his mentors at UCSF and with Randy, and their collaboration continued for decades. Nearly 20 years after their first joint publication, just a few years ago, they co-authored a piece in intensive care medicine titled Integrating Palliative Care into the ICU, a Lasting and Developing Legacy, that reflected on 25 years of progress in integrating palliative care into critical care settings, emerging models of care, and priorities for the future. And I particularly appreciate how this illustrates that truly meaningful mentoring relationships can thrive across institutions and endure over time. Dr. White's presence here today reflects a long legacy of rigorous scholarship in our division, and we're really honored to have you here today. So thanks, Bree.
Oh, thank you so much, Aaron, for that really nice introduction. And it is such an honor to be here, both for the Butler Lectureship and also just to be back in Seattle with Randy's people, essentially. So thanks so much for the invitation. And I'm really looking forward to the rest of the day, too, the retreat with the fellows and talking about what it takes to get through in these interesting times in academic medicine. Before I jump in, are we okay on the slides? Remotely, can people see the right view? Yes, good. Okay, I'm going to keep going.
Yeah, we can see the right view. It might be a little bit helpful to speak a little bit more towards the microphone.
Okay,
there you go.
I have
Perfect.
2 different microphones.
I
so
see.
Get to
No,
pick
that
which
sounds
people get to
good.
hear me today. How about this? Is
That's
this better?
perfect.
All right. Okay. Well, someone chime in and tell me if I need to speak up. All right. So today I'm going to be talking about achieving patient-centered care in advanced critical illness. This is my research funding and other financial disclosures, none of which pose a conflict with what I'll be discussing, but I will discuss several of the trials that were funded by the NIH. And what I'd like to do today, actually, it looks like the top of my screen is being cut off, but we can probably fix that. So there are 3 things I want to do. First, I want to summarize problems that arise in ICUs related to achieving patient and family-centered care. Then I want to make the case that the way we've traditionally or historically thought about and conceived of the problem is flawed. And then finally, I want to discuss trial results, including some done here, that point to a path forward to improve patient and family outcomes in the ICU setting. Okay, so the issues that we're talking about at the level of the ICU and the public health issues, I think there are 3 core problems. First, we know from lots of research over the years that care is frequently, at least appears to be, misaligned with patients' values in the sense that critically ill patients often receive more life-prolonging treatment than they would choose for themselves. And this is from data both asking surrogate decision makers to reflect back on it and patients who survive to reflect back on it. We know that the experience of having a critically ill loved one is incredibly distressing to the family and surrogate decision makers, both in the moment, what we call the peri-traumatic distress, and then also when you measure long-term outcomes, there are high rates of psychological symptom burdens like depression, PTSD, and anxiety. And then finally, this is extremely expensive medical care that we're providing. $82 billion were spent on critical care the last time this was measured in 2005, which is just a little bit south of 1% of the US GDP. Now, my focus is not on the economics of this, but I think we can all agree that care that is being delivered that is not consistent with what a patient would choose for themselves is inappropriate or wasteful care. Advance. There we go. Okay. And because this is grand rounds rather than only pulmonary and critical care, I want to make sure that I also address some of the upstream issues before patients even land in the ICU. Many of you, especially the general internists in the crowd, may be saying, listen, this is an issue that needs to be addressed before patients get to the ICU. And I absolutely agree with that. Advanced care planning is a critical way to make sure that patients who never want to cross the threshold of an ICU don't end up there. And I think redoubling our efforts to make sure that those goals of care conversations are happening both in the outpatient setting and when patients are admitted to the hospital, but before they get to the ICU, there's a good goals of care conversation. However, that's not going to solve the problem. And the reason is what I think many clinicians know, but what Terry Freed articulated really nicely in this New England paper from now more than, I think, 23 odd years ago. Terry took a group of seriously ill patients with advanced cancer, CHF, and advanced COPD, and gave them a variety of scenarios and asked, if you had X, Y, and Z circumstances, would you be willing to undergo intensive treatment? And what she found is that in this group who had a seriously limited life expectancy, more than 80% would be willing to undergo a month of intensive care for a less than 50% chance of survival. And so what I think that means is that advanced care planning isn't going to keep everyone out of the ICU with advanced illness, because many of those people, if there's a reasonable chance of a reasonably good outcome, are willing to give it a shot. And so what that means is that there's, I think, a core part of being an intensivist is the ability to navigate those difficult conversations in the ICU setting. So what's happened in this regard? And I want to walk you through some historical studies that I think give some insight into how the problem has been conceptualized that I think hints at a bit of where the field has gone awry. So the first is the support trial. And this was a landmark study conducted now more than 30 years ago, in which this was actually the first cluster randomized trial in healthcare delivery in the inpatient setting that was published. This was done, almost 5,000 patients across a variety of academic medical centers with serious illness were randomized to what was called the support intervention. And basically, this was an intervention that had a couple parts. First, physicians in the intervention group received estimates of the patient's likelihood of 6-month survival, their likely outcomes from CPR, and their likelihood of functional disability at 2 months. And then second, a specially trained nurse elicited the patient's preferences from the patient or the family and shared this information with the clinical team. So really essentially about an information gathering and an information conveying intervention. And unfortunately, the intervention had absolutely zero effect on end-of-life care or costs. So these are the intervention outcomes that they measured. The median time until a DNR order didn't vary across the groups. The percent of doctors who knew what their patient's code status didn't vary across groups. The percentage of patients who died on a ventilator or comatose in the hospital didn't vary across groups. The proportion of pain actually died with pain was almost statistically significantly more in the intervention group, and resource use was no change across the two groups. So a very big disappointment for the field in terms of the thought that this kind of intervention would fix the problem that was endemic back in the late 90s. And when you look at the conceptual basis for this intervention, it was really grounded in what's called either traditional decision analytic theory or conventionally or colloquially the rational actor model. And the idea here is that this intervention about giving information and exchanging information was grounded in the assumption that giving good information about the likely outcomes of treatment and the patient perceived value of those treatments would reliably lead to decisions that are utility optimizing, logical, and rational. And I think there's a lot of reasons to think that should work, right? First, it's the foundation of informed consent in American medicine, but also a lot of work over the last 20 or 30 years has documented very severe deficiencies in what I would call information exchange as it relates to prognosis, values, treatment options. And these are just a few of the studies that have highlighted some of these issues. So this top one, prognostication during physician-family discussions about limiting life support in ICUs, was one of my first publications. Randy was the senior author. We used remember that small sample of 60 or 70 audio recordings he had at 4 or 5 Seattle area hospitals. And we found that there were frequent omissions of key prognostic information. And also in a subsequent paper, we described quite confusing language in terms of how doctors discussed prognosis. Leslie Schuneman and Jared Chiarcharo, mentees of mine, used a bigger data set and analyzed the extent to which clinicians elicited patients' values and preferences during goals of care conversations in ICUs and found absent or incomplete elicitation of patients' values and preferences quite commonly. And then finally, Yale Schenker used, I think, the same data set that Leslie and Jared used and found that physicians frequently failed to disclose during these ICU goals of care conversations any option other than full intensive treatment. And in particular, rarely were there conversations about what a palliative approach to care would look like or what a time-limited trial would look like. Okay, so because of this, Chris Cox and a group of us called the Provent investigators felt like it would be worth revisiting whether an information-focused intervention that was actually scaled for comprehensibility to families and delivered in a reliable way might actually change outcomes. So this was another run at whether the rational actor approach, really giving good information, would change decisions. And so Chris did an amazing job. He's at Duke, did an amazing job of developing a very simple, very user-friendly, low health literacy-friendly decision aid for the surrogate decision makers of patients receiving prolonged mechanical ventilation. We did a randomized trial in 13 US ICUs among 277 patients receiving prolonged mechanical ventilation. And essentially what the intervention entailed, what the decision aid entailed, was the decision aid gave personalized prognostic estimates for hospital and 1-year survival. In a very comprehensible approach, both giving the numbers and then using what's called a wall of balls to convey the risk estimates in a way that doesn't require high numeracy. Then there was a portion of the decision aid that was about conveying the different treatment options. And essentially it was full intensive treatment, full comfort-focused care, or in the middle was framed out as a time-limited trial or another trial of intensive treatment. Then there was a values elicitation exercise that the families filled out to really think through what are the patient's values and preferences. And then finally, a summary sheet was printed out, given to the team, and that was formed the basis of a structured family meeting in advance of decision-making about trach. And unfortunately, essentially, this intervention was stone cold negative. The intervention had no effect on ICU length of stay, no effect on healthcare utilization, no effect on essentially goals of care decisions or decisions to transition to comfort-focused care, no effect on surrogates' 3 and 6 month psychological outcomes. And then also concerningly, even though they got very clear risk information, no effect on the accuracy of surrogates' prognostic expectations. And surrogates were quite inaccurate in their expectations. And then finally, there was a portion of the intervention that asked the surrogate to articulate what they thought the patient would choose for themselves in terms of treatment. And then we looked at what they actually chose, the surrogates chose for the patient. And what we found is that surrogates were on average overly aggressive, with 43% favoring a treatment option that was more aggressive than what that surrogate reported they thought the patient would choose. So something else is going on here other than problems with information transfer. I think there was good reason to push down this line of thinking, though, and this approach to developing interventions. This is a Cochrane review of more than 100 studies of decision aids of various types across a variety of health treatment decisions or screening decisions, more than 31,000 patients. And essentially, the conclusion of this Cochrane database review is across a wide variety of decision contexts, people exposed to decision aids are better informed, clearer about their values, and have more accurate risk perceptions. Growing evidence suggests that decision aids may improve values congruent choices. So that's not what we found, and that's not, the support trial didn't show that. Chris's Provent decision aid trial didn't show that. What's going on here? Well, I think many of you, both in the room who do pulmonary and critical care, and those online who do palliative medicine or inpatient internal medicine, are probably thinking, well, that's not the core of the issue quite often, right? Maybe it's a factual thing when you're thinking about a PSA test, or which colorectal cancer screening approach to take, or which OCP to take for birth control. Those are the kinds of decisions for which a decision aid might really address the core issue. But the things that we deal with in the intensive care unit, there's so much more of an overlay of psychological and emotional complexity that a factual decision aid just doesn't address. That would be my hypothesis about what's going on here. And so I think I've just given away what I want to convey on this slide. So another one of the studies that we did early on when I was at UCSF is we enrolled almost 200 surrogate decision makers who were actively involved in making decisions for a patient at high risk of death in an ICU. And we gave them on a probability, we gave them a piece of paper with a 0 to 100 probability scale. And we said, what do you think your loved one's chances of surviving to hospital discharge are? They put a physical mark on the probability scale, which is, anchored on the left side with no chance of surviving, on the right side with will certainly survive, and with, probabilities in between. And essentially, then we turned on an audio recorder and said, can you tell us a little bit about why you put the mark where you did? And what was really important about what we found is that very, very few people, less than 2%, said, because that's what the doctor told me. And instead, what emerged was a narrative that was much more complicated. And sometimes it had to do with what the doctor told them, but in combination with other considerations that they brought to the table. Their understanding of the patient's will to live, the patient's history of survival, i.e., this is what the doctor told us the last time, that he was going to die in the ICU. Their observations of the patient at the bedside. If he looked pink and warm, that made them have prognostic expectations that might differ from what the physician said. Surrogates' faith and optimism drove some people's decisions. And surrogates' belief that their presence at the bedside would change the prognosis. This is called performative optimism. Was something that people also said, I put this here because we've been here every day. I put this mark here. His prognosis is good because we're here with him. We're praying with him. These are not the kind of things that are going to be overcome by a factual decision aid. Another study in which we interviewed surrogate decision makers and asked them about the experience of making end-of-life decisions for someone in the ICU also revealed that what surrogates seemed to be struggling with was not the factual issues, was not the sort of gist of what was happening with their loved one. And instead, the main findings from the paper were that surrogates experienced significant emotional conflict between the desire to act in accordance with their loved one's values and two competing factors. One, not wanting to feel responsible for their loved one's death, and two, a feeling that the morally right thing to do in general is to pursue any chance of recovery. Again, things that even in the face of good information, these psychological and emotional factors may not be sensitive to the kinds of interventions that focus on information. And so along with Nick Dion Odom, who's a great nurse researcher at UW, we wrote a viewpoint in JAMA a few years ago in which we argued that it's time to reconceptualize how we think of supporting surrogate decision makers making medical decisions in the ICU setting. And essentially the argument is a version of what I've already laid out to you, and goes something along the lines of decision support that focuses on medical facts alone mistakenly treats the act of deciding for others as a purely cognitive exercise, rather than one that also entails emotional and psychological dimensions. And we argued that interventions, if we are hoping to improve the decisions that are made, need to attend not only to the factual aspects of the decisions, the cognitive aspects, but also to the psychological considerations and the emotional considerations. And so before I get into some of the more modern interventions, I want to just think for a moment with you or show when you think about from the public health standpoint, well, what do we want to see to help us be convinced that an intervention is useful? What would count as an intervention working? I think there are several domains of outcomes that are worth thinking about. And I organize them along the lines of patient level outcomes, family level outcomes, some process outcomes around communication and decision-making, healthcare utilization outcomes, and then also clinician outcomes, things like moral distress and job strain, which I think are post-pandemic are increasingly prevalent on health administrators' minds about how can we retain our workforces. So these are the general domains that I think about when I think about studies, what studies should be assessing when they assess these interventions. And so I think the work that Randy has done, and I don't want to belabor it too much because I know that you all are probably deeply familiar with these studies, and many of you probably participated as intervention recipients in the studies. But I think Randy did an amazing job of recognizing the human element of this and then translating it and attempting to translate what needs to be intervened on into sensible healthcare delivery interventions. And that's sort of Randy in a nutshell, right? Both very human and very practical, very savvy about these sorts of things. And so Randy, along with Ruth Engelberg and Patsy Treese, designed an intervention that they called a communication facilitator, which, as many of you probably know, involved a specially trained nurse who was trained in family support and mediation therapy or theory, who worked with the families in the ICU to deliver tailored support to families based on their coping styles, and then also facilitated communication with the ICU team and worked to preemptively identify and address nascent conflict. This was a multi-center randomized trial, 268 family members of 168 patients with respiratory failure and high risk of death. And as many of you know, I think there were a number of positive outcomes of this trial that were very promising. So these are, can you guys see my, yeah. So depression, anxiety, and PTSD outcomes at 3 and 6 months. In the control compared to the intervention, they found lower rates of depression at 6 months, as well as lower rates of PTSD at 6 months as well. And the PTSD signal was especially important because many of you know that a few interventions in this field, one of mine included, have actually raised rates, symptom levels of post-traumatic stress in participants. And so it was especially heartening to see that the communication facilitator intervention decreased those rates or had a trend in that direction. You know, I think it's also important to characterize this intervention as the interventionist was external to the clinical team. So, for example, it wasn't Randy and team coming in and saying, we're going to retrain the nurses and retrain the clinicians. Instead, this was adding someone to the healthcare processes without necessarily reshaping what the clinicians did on their own. The other thing they found was a significant decrease in ICU length of stay among decedents. You see decedents in the control arm on average 28 days in the ICU, intervention arm on average 7, almost 8 days, with a concomitant significant decrease in healthcare costs. And so to his credit, Randy recognized, listen, there's multiple hypothesis testing going on here. This was a relatively small study. It needs to be repeated. And also to his credit, he went on to do that study. And so he, I think this was when he was on his sabbatical in Paris. He and Ellie Azoulay and Nancy Kentish Barnes did a randomized controlled trial in French ICUs of the communication facilitator intervention. And unfortunately, what they found was a stone cold negative trial. No improvements in the intervention arm in family symptoms of depression, anxiety, PTSD, ratings of goal concordant care, or experiences of serious illness as rated by the family. And then around the same time, I had an R01 in which we were doing a randomized trial of theoretically a different intervention, grounded in different theories of communication, but at the macro level looked a lot like the communication facilitator. We had a nurse and social worker-led intervention that focused in the very same ways on engaging with families across the ICU setting. This was called the 4 supports intervention. And it was also stone cold negative, published earlier this year. No improvements in family symptoms of depression, anxiety, PTSD, ratings of the quality of communication, and patient-centeredness of care. And both of these studies, we had both the study that Randy, Nancy, Kentish Barnes, and Ellie did, and ours had a companion qualitative piece. And for the healthcare delivery researchers in the audience, pairing qualitative methods and embedded ethnography alongside a clinical trial is an incredibly valuable way to begin to just get some hypotheses about why an intervention either was unsuccessful or why the intervention effect was varying across sites, for example. And in both of these studies, the qualitative companion piece suggested that the external interventionists were not well integrated into the team, such that they were sort of an add-on appendage to care rather than a part of care that very much shaped the family's experience. You know, our intention with the forced supports intervention had been these nurses will really drive support. And in theory, or in practice, in part because of the sort of large and complex ICU teams already, that is not what appeared to happen. So I think it's too early to say that this external interventionist model is not the right model, but we have a couple studies that are very well done with careful ethnography and interviews with participants that suggest that this is one of the issues that needs to be very carefully attended to, the integration with the clinical team, if there are going to be future studies in the ICU setting of what I think of as external interventionist interventions. Okay, so a different approach, rather than bringing someone external in, is to really re-engineer the healthcare delivery processes around family support in ICUs. And I want to tell you about a trial that we did that was published now 7 years ago in the New England Journal attempting this. And so we conducted a stepped wedge cluster randomized trial comparing usual care to what we call the protocolized family support intervention, which was delivered explicitly by the members of the ICU team, essentially the doctors, the nurses, and the social workers. We brought no one else in, and there was no increase in the FTE of people involved. This was really just reorganizing care delivery for family support into a structured family support pathway and giving nurses a much stronger role in the process. We randomized 1,420 incapacitated critically ill patients at high risk of death or disability, and the outcome measures tracked that conceptual grouping that I showed you earlier. We measured surrogates, long-term psychological distress, measures of the patient-centeredness of care, measures of quality of clinician-family communication, and then ICU length of stay and hospital costs. This is just a description of the partner intervention. That's what the intervention was called. As I said, in each ICU, 4 to 6 of the already employed ICU nurses who were identified as leaders in this space in their ICU became the partner nurses. They assisted with the institution of a protocolized family support pathway, and they underwent advanced communication skills training for the role. Each of them went through a certification process. So before they were released into delivering the intervention in simulations, they had to show that they had the skills to deliver the intervention as planned. And so you don't need to see the details of it, but the idea is that the nurses met with the family on day one, established an emotionally supportive relationship, and then made sure family meetings happened. They scheduled a family meeting within the first 48 hours. They sat with the family before the family meeting to help the family get ready for the family meeting. They were part of the family meeting and we trained them to particularly nudge to talk about prognosis, to attend to the family's emotions, and to explore the psychosocial aspects of what might be contributing to decisions being made. And then they sat with the family afterwards to provide emotional support. And essentially, it was this cadence of meeting with the family every day, with the nurse and the family for emotional support, interspersed with structured family meetings every 5 to 7 days. That was the nature of the intervention. This is just an example of what the partner nurses worked through with the families in advance of the family meetings. So on the right here, you see they asked the family to write down what are their main questions. And then there was what's called a question prompt list, in which they asked the families, which of these things are most on your mind, with the idea of trying to nudge towards clearer conversations about patients' values and treatment options. And then finally, there was a time that the nurses educated the families about the kind of questions that the doctors would be asking them in the family meeting, largely as an opportunity to help educate the families about the role of a surrogate decision maker and substituted judgment. And so what we found is the primary outcome measure was 6-month psychological outcomes, no change in depression or anxiety amongst surrogates, and no change in their PTSD symptoms as measured by the IES, Impact of Event Scales. But on every other outcome measure, the trial was positive. So significantly improved ratings of the quality of communication in the intervention arm, significantly improved ratings of the patient and family centeredness of care in the intervention arm. A lower score is better on this measure. And then significantly decreased ICU length of stay among decedents, 6.8 day length of stay in the control arm versus 4.4 in the intervention arm. Overall hospital length of stay was shorter in the intervention arm compared to the control arm. And then significantly for the health system, they were very interested in, is this going to cost us money, save us money, or be net neutral? And so we did a careful cost analysis, and we found that the intervention significantly decreased healthcare costs. And this was something that the hospital presidents, they wanted to know that, if we're improving families' perceptions of the patient-centeredness of care and the quality of communication, are we also, is it costing us a lot of money? Is it saving us money? And as I said, this is not the place that I choose to focus, but I think we do have to be strategic about understanding from the perspective of healthcare finance. People will want to know, are we going to have to pay more for this intervention, or will it save us money? And then interestingly, just this month, right, we're still in September. Yeah, so this, a group in Switzerland did essentially what they conceived of as a confirmatory or a replication study of the partner intervention. And they did it in 16 ICUs in Switzerland. It was a cluster randomized trial, more ICUs than we did in the partner trial, a few fewer patients, but 885 family members, the same type of nurse-led multi-component family support intervention. And what they found is that it improved the quality of communication as rated by family members and improved family members' ratings of the cognitive and emotional support provided by the ICU team. They did not report length of stay or hospital costs. I think that's going to be coming in an ensuing paper. But I think it's heartening to see a replication study done in a very different healthcare delivery system, conceptually grounded in the same way, and still having important positive outcomes. And then one more study that's been done before I tell you about a study that is almost over, and I think an interesting one worth knowing about. So this study was done by Dong Chang at UCLA, and it's a very different way of intervening. Rather than the intervention focused on bringing in the full members of the interprofessional team, this intervention was focused on getting structured family meetings happening and really training up the intensivists to have better goals of care conversations. So it was a medical communication skills training intervention for the docs. It was a pre-post study, so I think in 3 ICUs, so we need to take the causality claims with a grain of salt. And it was relatively small, 209 critically ill patients at high risk of death. The intervention, as I described, was proactive family meetings within 1 to 2 days of admission and then serially thereafter. And then physicians received communication skills at the outset of the intervention and shared decision-making, providing emotional support and centering care on the patient as a person, as well as a nudge towards getting doctors to frame intensive care as a time-limited trial rather than sort of speaking about intensive care as open-ended, essentially as a way to help families begin to understand the need to be thinking about what happens if things don't go well. And what they found essentially is that the ICU length of stay after controlling for confounders was shorter in the intervention arm compared to the control arm. The use of mechanical ventilation was significantly lower in the intervention arm compared to the control arm. No difference in hospital mortality, and interestingly, no difference in family satisfaction. So we're definitely not seeing all signals pointing in all the same direction for interventions that focus on reskilling the existing ICU team. But multiple studies of interventions that are focused on the ICU team as the intervention target rather than external interventionists, what we're seeing is interesting suggestions of positive results. And then I just want to shift gears a little in light of, Randy Curtis's really remarkable focus on integrating palliative and critical care in ICUs. I very much agreed with Randy that this is a place to push. And it was one of the few studies that he left undone. He didn't quite get to this one. And Rebecca Aslickson wrote now more than 10 years ago, the field could benefit from a definitive, well-powered, well-designed, multi-center controlled trial evaluating proactive palliative care in the ICU as compared to usual care. And so we undertook this study. Study started in 2022. We have just completed enrolling the 500th patient in the last couple months. We're in the midst of 6-month data collection, so I can't tell you what the results are, but I just wanted to flag for you that this trial is coming and explain a little bit about what the intervention arm entailed, because it wasn't just essentially a run-of-the-mill palliative care consultation. We really sought to get the palliative care team and the ICU team working together rather than what did Alex Smith call parallel play, I think is what often happens, right? Where you've got the ICU team doing their thing and you have the palliative care team doing their thing, and it's not quite theoretically as effective as if both are doing the same thing and working with the family together. And that's very much what we sought to do with this intervention, is have the palliative care consultants collaborating with the ICU team every day. And it was a co-management model where every day they made decisions about palliative care domains of care, pain, symptom control, family support, had family meetings together with the families, and then this essentially continued throughout the ICU stay and then continued into the hospital wards. The ICU team dropped off, but the palliative medicine team continued on. And so, as I said, this intervention, we have really tried to make sure that we are capturing outcome measures relevant to patients, families, and society. And so we have the primary outcome measure is families' look-back ratings of the patient-centeredness of care. We're also collecting post-traumatic stress symptoms, surrogate symptoms of anxiety and depression. And then patient and family level outcomes are, hospital survival, duration of survival through 6 months, days alive outside the hospital, functional status at 6 months, measures of goal concordant care. And then we're looking at some interesting, what I think of as sort of process measures. So Chris Cox did a nice job of developing a scale for unmet palliative care needs. And so we're looking to see if on day 5 of the intervention, there's any difference across the arms, essentially as looking to explain what factors and what was the causal pathway through which the intervention has any positive effect, if it does. And then finally, a bunch of healthcare utilization outcomes. And so we are, as I said, this study is done. We've enrolled 500 patients. It's twice over the largest study of palliative care consultation in the ICU setting. And we expect the results, I think the last 6-month follow-up will happen in 2 or 3 months. And so probably not ready for ATS next year, but I expect it will have results very soon. And we'll see if bringing in what I think of as the most skilled psychosocial supporters in the hospital setting actually changes outcomes at all. We don't know, by the way, the investigative team, we've been sort of going back and forth about even guessing whether we think the intervention will be positive or not. It's not quite as straightforward as you might think. And so I really don't know what this will show. Okay, let me end here. I want to make the 3 main points that I started with. Making decisions for others in advanced illness raises complex cognitive, psychological, and emotional challenges. Information-focused interventions has been sort of the coin of the realm, or historically was the coin of the realm in the ICU setting, and they've generally been ineffective. But interventions delivered by the ICU team that target informational, emotional, and psychological needs show promise. And I think we have very much Randy Curtis to thank for moving this field in the direction that it's moved. Thank you.
Are there any questions from the folks in person?
No one is forthcoming. Oh, one person is forthcoming. Okay.
Hear it.
Do you need this? Do you need me to? I'll repeat it. Yeah. Okay.
So, thank you for that great talk. Summary of this field that has evolved a lot in years. Wondering about the counter argument that I can anticipate ICU teams take to this, which is I'm too busy, I don't have time to do this, and I don't have the training to feel like I really belong in this space. So when you think about these ICU embedded interventions from that, I think did you do any training of the rest of the ICU besides this sort of special trained nurse in your study?
Yeah.
And sort of what are the strategies that you think of overcome the cost was the message?
Yeah. So the question was, many clinicians may feel insufficiently skilled to do this, particularly outside of the nurses who were trained up in the partner intervention. They may feel that they don't have the time to do this. And did we attend to that in the intervention? And if we didn't, how should we in the future? That's a great series of questions, very much the ones that I've been thinking about myself. So we did not intervene on the doctor's communication skills very intentionally because we were trying to develop a pragmatic and scalable intervention. And as you know, doctors are a pain in the butt to train. Myself being like a great example of that. It's also really expensive to train docs. And so the scientific question was, is it possible to change outcomes without doing so? I don't think it's the best intervention, right? I think the best intervention in a, time and money enriched world is to really put doctors through an intensive communication skills training. That's not what we tested here. And all we did for this intervention was alerted them to what's happening. And we essentially relied on the ability for the nurses to support the families, get the meetings to happen, and then the doctors to have the skills that they have to run them. And we did see an effect. I think it's important it didn't affect long-term outcomes, but we saw important, I think, other outcomes in terms of patient-centeredness of care. I think that the right intervention to do as a next step is a big cluster randomized trial and maybe even a 3-arm trial. There's a usual care arm because I think we need to replicate the findings, number one. So I think you need a usual care comparator. One arm that is nurse education only with the family support pathway, and a third arm that's family support pathway, nurse education, and doc education. That is an expensive trial to do because this is a unit level or an ICU level intervention, so it has to be a cluster randomized trial. The other thing, this gets into something we haven't talked about, but I have very much focused the last year on and have had NIH funding to develop scalable technology platforms to train doctors in these skills, because I have viewed this as a shortcoming in the field. It's just, we have VitalTalk, which is an amazing approach to training, but it is available to the select and privileged few across the country. We have several 100,000 docs who need these skills. VitalTalk can't manage that. They absolutely recognize that and are exploring other approaches too. But we need technology enhanced, low touch, low cost interventions to give docs these skills. So that's very much what I'm working on. Thank you. Yes.
Thanks, this is something that's been stuck in my craw for a while. I'm just interested in thoughts. It seems like we're not the only country that struggles with this, but we are the one that struggles with this. There's also been a lot of literature that the more ICU beds are built, there are a lot of non-patient centered reasons that drive why we deliver intensive care to a lot of people for whom the chance meaningful recovery is low.
Yeah.
Is that a cultural thing?
Yeah.
Or
Yeah, that's a great question. So I think it is a particularly American thing. We don't have a healthcare system. We have a set of different healthcare delivery companies. Some are for profit, some are not for profit. There's not a social safety net in the grand sense that there is in Europe. And I think these things, these structural and context things are relevant because, for example, in France and in the UK and in several other European countries, do you know who is the surrogate of record for an inpatient? It's the physician. It's not the family. And these are also, I think, not coincidentally, countries with nationalized health insurance. And so there is I think at least at the theoretical level, there is a promise for basic care in these countries that comes with more authority given to clinicians and maybe society in some broader way to say, here's the limit of care, and we're giving doctors discretion to make judgments in individual cases about that limit in a way that we don't have in the United States. I mean, we don't have the basis for that. If we were to say, listen, this is part of the social contract, we will guarantee you good primary care and care throughout your life. But what we can't guarantee you is everything near the end of your life. And so, I mean, that's the mental model that I carry around in my head for why things are the way they are in the United States. I also think that in the last certainly year, but 4 or 5 years, I think there's also been growing distrust of science and growing distrust of authority in such a way that I don't think there would be a lot of receptivity to giving scientists, doctors being perceived as scientists, more authority to make these highly sensitive and value-laden judgments autonomously. Yeah, Chris had a question, and then over here.
I really think your child, but if it is, how do we maintain fidelity of your child to be rolling? Because, I agree, another child would be very better, but
yeah,
how does a place like Montline or Harborview make sure that we have the same fidelity file?
Yeah. Well, oh, right. Yes, I need to repeat your question. Essentially, Chris Goss is saying, how are you going to, even if this is positive, and he says it's going to be positive. Thank you, Chris. Even if it is positive, how will we roll this thing out with fidelity across broad community hospitals? So I'll offer 2 things. One is a non-response, but I want to explain. We chose to do a carefully controlled efficacy trial because the field is littered with negative interventions, and because the first order question when you're doing research is, does the thing work when delivered with high fidelity? And so that's what we intended to do. We threw a lot of resources at making sure that this intervention was delivered with high fidelity, and in fact it was. So I think we're going to answer the question with the trial. We did design it in mind. We didn't design an intervention that is so ridiculously complicated that no community hospital could do it. It's a palliative care intervention paired with the clinical team and the palliative care team and the ICU touching base every day. I think that is scalable. And I think, just like hospitals have been able to mobilize QI teams to make sure that the CAUTI protocols are followed and the central line infection are followed. If the financial incentives are there, then I think that this is a very feasible intervention to get high fidelity with. Dr. Van Horn, nice to see you. Yes. Okay, I'm Doug B. It's important to know that the other Doug White was Doug A.E. White, and that, I kid you not, that stood for Douglas Albert Einstein White. I kid you not. I kid you not.
So that was a great talk. And you started off by talking about upstream factors for the feminines. And I'm just wondering, have you ever looked at just trying to keep people out of the ICU? And walk to say we have polls, say, you aren't feeding. I don't think you can say out of the ICU. I'm not sure that's the case, but a lot of times when families bring someone into the hospital, they're looking for reassurance. Now looking for cookies and peace. And so I'm just wondering, and we each have our own culture. So, part of the problem probably is integrating with the teachers. receiving. I'm just wondering, and I don't know where this intervention would take place. The ER is probably too. I'm not careful. Has anyone looked at that, like saying this is not necessarily you?
Yeah. So the question was, what sorts of upstream interventions have there been to keep people out of the ICU who presumably wouldn't want to be there after a careful, emotionally supportive conversation? And I would say that the best ones are, I'm thinking of the work that one of our classmates, Karita Grudson, did. Karita's an ER physician in New York City, and she did a big cluster randomized trial of a palliative care intervention in the emergency department. And it was regrettably a negative trial for changing rates of downstream utilization of more intensive treatment. So I don't have I feel like I'm just missing a big answer to that, but there's not one thing that jumps out that says, yes, this is outside of sort of the general thought that PULSTs and advanced directives and good basic goals of care conversations happen when you enter the hospital. I have not seen evidence for a particular intervention other than that.
Great talk. And something maybe less practically oriented and more theoretical, but you alluded to the differences between us and what surrogates think their loved one would want versus what they choose would often be much more less. And to me, that often manifests as a guilt factor about what have you tried to implement in your child to see other people and rest of this?
Yeah, I mean, I think our palliative care colleagues do an amazing job of this. And some of it is not normalizing, but making acceptable choices to do something other than full court intensive treatment. And a lot of that has to do with affirming to the family that the choice to focus on comfort rather than life extension can be a compassionate choice, can be a loving choice, can be a patient-centered choice. And this notion of it being a loving choice, I increasingly, I think that this is an important part of what we need to attend to, which is there are identity issues that come up for surrogate decision makers. And we see this in the interviews. They don't want to feel like they're the kind of person that pulled the plug on their loved one. And so I think a good deal of the work that we need to do is to find ways that when appropriate, when it seems that a focus on comfort is more consistent with the patient's values than a focus on life prolongation, is to help families understand that is a loving decision, that can be a loving decision. And that is an approach that the doctor validates as what he or she thinks is the right thing, given what we know collectively about the patient as a person. That's the human work that I think is so important. I'm not sure we'll ever like fully bake it into trials. It could very well be an intervention component, as making sure we're training doctors to do that. But I think our palliative care colleagues are probably sitting here saying, yeah, this is like all that we do all day is try to help people do that. Yes, yeah.
So communication between the surrogates and the care providers is key. Probably to some degree that helps establish trust with the care providers. So it seems to me that a challenge in implementation is the churn of providers that we have in IC, both on the nurses side and on the physician side. So how do you think that impacts implementation of this strategy, and what are some ideas about that?
Yeah, it's the churn in an ICU and the 5 days on, 5 days off, or 7 days on and then you're off. The different ICU docs is a huge issue. If the claim is, and I think the claim is, that making these decisions on the part of a family requires some trust in the judgment of the person across the table, and that trust in their judgment has to be earned. I think we especially see this in diverse populations, and those who are anti-science and those who felt historically discriminated against. That's where trust, I think, is extremely hard to build. And so thinking about, there are two potential paths forward that I think are reasonable. One has been tried. I mean, One is just really training doctors to conceptualize that part of their role is in communication. And one of the purposes of the communication acts is to do the work to show that you're trustworthy. Like you have to be trustworthy first, but you also have to show that you're trustworthy and demonstrate that and earn trust. So I think a lot of doctors, I think we assume that people will trust us because we're, well trained and we're at the sort of apex of medical specialization, and that's just not the case. I think we need to retrain that mental model. The other approach is one that I think is not feasible in practice, but has been tried, which is it's been tried in both pediatric ICUs and adult ICUs, is that you have what's it called? They've called it like a long stay attending. So one attending for patients that have been there for more than 5 or 6 days and foreseeably are likely to be there for a long time, there's just one doc who takes care of them their entire stay. And he or she may only have 2 out of the 20 patients on the service, but that's their job, is to be the continuity and the trusting person for these families over time. As I said, I don't think that that's feasible at scale, but it is people identifying the issues that you've raised. Okay, I think we're at the hour. Okay, thank you very much.
Thank you so much, Dr. Wright. That was wonderful.
Thanks, Hannah.
Thanks all for coming. See you next time.